All right, it's Mr. McCarthy. Today is 1/5/2021. We are in RT 210A, the second day of lecture, respiratory measurements and terminology. I left off yesterday with some abbreviations, prefixes, suffixes, and some root words just to get a good idea of some of the words, terminology that you're going to be dealing with. Make sure you guys continue to study those words, understanding those main ones we talked about that we outlined yesterday as ones you will see a whole lot. Okay. We are recording and we're going to start off with the directional terms today. Today, just for clarification, I sent out the email about in-person learning. And I said, whoever wants us to be in person, we're going to have to swap it out with Teams because, it's too many people to say, okay, I'll be here this day and Wednesdays, and I can't keep up with all of that. Okay. So what we're going to do is today I opened it up to the Alpha students who wanted to come in person. So if you were an Alpha student and you wanted to come in person, you were open to come in person today from 1 to 6. Tomorrow, of course, is our exam. So everybody will be here at your designated time for your team. Thursday, we start RT 210B, which is cardiac A&P. And that's when I will open it up to Omega students can come on Thursday from 1 to 6 if you would like. And we'll go back and forth like that. I will remind you at the end of the lecture. If I don't, remind me to make sure everybody gets an understanding. At the end of each lecture, I will let you know what's the homework, what to expect tomorrow, and so forth, okay? There's nothing you have to go and complete a week's worth of homework or try to go, knock out a whole lot of assignments. You're going to do it one day at a time. Only thing that you will go ahead is the reading. Look at the reading. Make sure you're studying notes out of the book. You should be highlighting in your book, things like that. And then as I give assignments, you can use that information from the lecture and from your reading to do your homework, all right, and to study. But as far as trying to knock out a week's worth of stuff, don't do that yet because you're just going to confuse yourself, all right? All right, so let's look at last night. I did the I've already done the attendance for today. If your homework was not turned in by 11:59 and you didn't contact me, I gave some people a little extra time to do it by 1 since it was the first day, and I didn't get any of those by 1s either. So if you didn't turn it in, you're absent for yesterday. All right, tonight when you do your homework, you turn it in, you'll be present for today, even if you're here. Okay, you have to do an assignment for attendance. Sometimes it may be my name is whatever, or I'm an RT student, yes or no, just for simple attendance. Okay, it's not for a grade, but it's for attendance. Now it does count. If you don't do it, it does come off of your homework grade for each unit. Like I said, RT 210A has 5 homework assignments. I may not assign them all, but they are 20 points apiece. If you don't do one, that's 20 off of that 100 that you already have. You already have 100 for the homework for A, 100 for the homework of B, homework for the C, and so on. It's only when you don't do it when I start taking those points off, okay? Now, those points in the long run can knock you down from that 75 to a 74, could be very important to you, so make sure you're doing your homework, all right? And they help you with studying for the exam and all of that. All right, so let's share my screen to the lesson plan. All right, directional terms. You're going to see a lot of terminology as far as where are we talking about these things on the body? Where at on the body? What is it up? Is it down? The front, the back? A lot of these terms I'm pretty sure you are familiar with. All right, but of course, don't forget that the left and the right is very important. When we say left, we're talking about the subject or the patient's left, not your left. All right, left and right is the patient's left and right. Okay, that's very important. So for instance, this is a picture of the human heart. Okay, this is the human heart. It will be like it's my heart. Okay, if you're looking at it, this is the right side of the heart, and this is the left side of the heart. It's the patient's right, the patient's left. Okay. All right, Lori, can you hear now? know what she's doing. I don't know why she can't hear. Oh, what? Not misleading. All right, 1 second. All right, so this is the patient's right, this is the patient's left. Very important, because when it comes to the heart has two circulations. It has a pulmonary circulation and it has a systemic circulation. Pulmonary circulation is the blood that's coming on the right side, which goes to the lungs. Systemic circulation is the blood that returns from the lungs into the left side of the heart, which goes to the body. Okay, so it's split right down the middle. You have a right and a left, and there's several things we want to learn about. Each chamber of the heart, each valve of the heart, the great vessels of the heart, arteries and veins, fibers, the electrical conduction, the blood flow. You're going to learn all of that starting on Thursday, okay, when we get into the heart. But it's very important, because if you are dealing with a patient and they have something like COPD, which is a respiratory disease, chronic obstructive pulmonary disease, which comes from smoking, it's going to be a right-sided heart problem. So you got to know where you are, which ventricles and which atria, which vessels are you talking about? So right and left is very, very important. Same thing with the lungs themselves. Right lung and left lung, they are totally different. All right, and they have segments that you have to memorize, little pockets in each lung. All right, when we get to that part. So very important to know those terminology. Okay, right and left. Then you have lateral. Lateral means to the side. Okay, something that's lateral is on the side of the patient. Medial is tight, kind of when you say towards the middle. All right, towards the middle of the body, like the torso. That will be the medial. Anterior would be the front, right? The front of the body. Posterior, toward the back of the body. Superior, of course, is at the top of the body, okay? For instance, we have a major vein of the heart, okay? A major vein, the largest vein in the body is the vena cava. You have the superior and you have the inferior vena cava. Superior because it's at the top of it. Superior at the top and inferior at the bottom. And it's one vessel. It takes all the blood from the body and dumps it into the right side of the heart, okay? And so that's important. You have the superior and the inferior. So the superior is at the top, inferior would be at your bottom. All right, dorsal, along or toward the vertebral surface of the body, like a shark. When you're in the ocean and you see that fin going across the water, you hurry up and get up out the ocean, right? That's the shark. That's his dorsal fin. That's the fin that runs across the back of his body, right, where his vertebrae is. That's the dorsal. So if you get stabbed or shot or have a tumor around your back area, you would say he has some tumors or some wounds on his dorsal area of his body. That's along his back, okay, along his or her back. Then opposite of dorsal is ventral. Ventral is around the front. The fin that is on a fish's stomach is his ventral fin, okay? Ventral is toward the belly surface of the body, okay? If you want to talk about the belly, you will be talking about ventral, okay? Caudal will be toward the tail. Caudad or caudal is toward the tail, okay? Toward the tail. Of course, cephalad will be at the head. I'm sure you guys have heard a lot of terminology that's encephalitis, encephalopathy, cephala, that's brain or head, okay? That's cephala here, right here, L. Cephalad means toward the head of the body. All right. Then you have terms that are talking about proximal or distal. Proximal means near the trunk of the body, and distal is farther away, okay, from the trunk. So like, and I use a lot of trauma when I talk about it. If somebody had some gunshots and they said he had 4 or 5 gunshots distal gunshots, that would mean they're away from the midsection, kind of toward the arms and down the arm somewhere, or down the legs. They're away from the trunk of the body, okay? And if they are proximal, they're right there in the midsection, right? They're right toward the trunk of the body, okay? So when we talk about proximal and distal, that's what we're talking about. All right, let me see if I have my PowerPoint. In your notes, you will have a sheet that looks like this. Some acronyms. This is old school acronyms. You don't have to know every single one of these in 210. All right, but just kind of go over those. Whatever you see that you saw in your lecture, that would be something you probably need to know. All right. High frequency positive pressure, HFPPV. You're not gonna need to know that in 210. Okay, and these FETs and FEV probably won't need to know those either. But there's some other ones. They just give you a whole list. This will last you throughout your whole respiratory career here, okay? Just a little something to help. You don't have to memorize every single one of these, but go through them and kind of start looking at some of them, okay? Like one of them is CaO2, that's total oxygen content. That's very important. ABG, oh, you're gonna love those. That's the arterial blood gas. That's what makes you a therapist, okay? Being able to, let me see, I don't have that in my notes. Okay. Well, if you don't, I'll send it to you. It should be in the note-taking guide, either in the note-taking guide or in the homework or something. It's somewhere. I know it's in there somewhere. But if you don't, I'll send it to you. Okay, no big deal. Thanks for telling me. But ABGs is what makes you a therapist. Being able to realize the pH and the acidity and alkalineness of the blood is what makes you a real therapist. Breathing treatments, guys, I'm gonna tell you this, and I'll tell everybody else. When I became a therapist, I saw people doing breathing treatments in the hospital and say, damn, I can do that. You know, any monkey can do that, right? And they making all that money too. But then when I got into respiratory, I found out that breathing treatments is like 0.5% of what you do. 99.9% of what you do is therapy, medicine, actually knowing what's going on with circulation of the blood. If the heart is messing up, the lungs are going to be messed up, okay? A lot of places, a lot of hospitals, you're not a respiratory therapist, you are a cardiopulmonary specialist in some hospitals, okay? That's just the name they give. Because we're going to work hand in hand, the heart and lungs, got to know them both down packed. How are they supposed to be behaving, right? And if they're not behaving, it's because of what disease process. How far along in the disease process are they? And how can I fix them and have a better life? All right, what is oxygen? What is it doing to the body? Can too much kill you? Yes, it can. So it's a lot of things in respiratory. I want you to make sure you understand. It's not just breathing treatments, okay? It's a lot of math and a lot of critical thinking. I call it layers. So sometimes when I stop class, I'll just stop and say, okay, guys, here's a layer question. That lets you know I'm about to ask you something that you're going to have to pull everything you've learned to answer it, okay? It's not going to be just stuff from 210A or stuff from 210B. When I get to C or D, I still need to know A and B and C, okay? You got to know it in order to answer those layered questions. When the physician presents you with a question or a problem, you got to know how to handle that. You got to know where to start, okay? It's all inclusive. All right, so let's keep on going. All right. So those are some of the directional terms that you will see, okay? Some of the directional terms that you will see in respiratory. All right, some abbreviations. Now, these first two are very important. The first two are very important. Big A is alveolar. Big A stands for alveolar. And when you see a little a, they're talking about arterial. Okay, big A is alveolar, little a is arterial. All right. So I'm gonna skip around a little bit so I can see, so we can put something together. Look at, where's my P? Oh, well, write this down in your notes. P, a big P stands for pressure. P stands for pressure. All right. And then, of course, what is O2? Somebody tell me what O2 is? O2, what is that?
Oxygen.
Oxygen. Okay, oxygen. Good. So I'm going to put some stuff together because this is how you're going to be reading a lot of things. Okay. Remember that gas exerts pressure. Okay. Every gas in the atmosphere is exerting a pressure. Okay. I told you yesterday that in order for gas to move or for liquid to move, it has to be a change in pressure. Okay. Has to be a change in pressure. And so gas will run away from pressure. So it goes from how many of you heard that, fluid or water, running water or gas or whatever, it goes from a pressure of high to low, okay? Everything moves from high pressure to low pressure, okay? If you have volume or gas in something and it's at a certain pressure, if it's a lower pressure somewhere else, it's going to go that way, okay? It likes to run toward the young pressure or the little least pressure. So I kind of call it the big pump, right? Gas runs away. He always runs away from pressure. So wherever there's a higher pressure, he's running away from it, okay? Remember that. So let's look at a few of these abbreviations that you will see. All right. P stands for what?
Pressure.
Big A stands for
Alveolar.
Alveolar. And the alveolus is the little air sacs in the lungs, okay? Alveoli are little bitty air sacs inside of your lung. We have 300 to 600 million of these. 300 to 600 million of these little air sacs. That's what they call them. They're alveolus or alveolar, okay? Also known as alveolus. And more of them will be alveoli, right? 300 to 600 million. This is where the magic happens, okay? The alveolar or alveolus is where the magic happens. That's where gas exchanges. So write that down. Write magic, and beside that, gas exchange. The word magic and that means gas exchange. Who can tell me what two gases you think are exchanging in the alveoli? The alveoli are deep inside the lungs, okay? What gases do you think are exchanging? There's only two. They go, you give me this, I give you that. Give me this, I give you that. Give me this, I give you that. That's going on all day long in your lungs. What do you think is happening? And we're going to get farther into that when we get to pulmonary AMP and all of that. But I just want to get you
oxygen
and
Carbon dioxide.
Ventilation, yeah, ventilation, which is carbon dioxide. Good. So when our body metabolizes, when you go to the store, you walk around, you live it, right? That's metabolism, okay? The byproduct of metabolism is carbon dioxide. That's the waste product, okay? We burn glucose and we burn oxygen. We use oxygen and burn sugars, right? And when we do that, we produce a waste product called carbon dioxide, all right? And you got to get that off of you. That's why you have to ventilate, right? Because ventilation is carbon dioxide. So we have to get that carbon dioxide off. Not too much of it, but you got to get it off. If you don't get it off, you go into respiratory failure, which is acidosis, because CO2 is a what? We said AKA. What did I say CO2 was? AKA what?
Acid, ventilation, respiratory.
See all of that?
Carbia
and apnea, right? So when we are metabolism, as I'm sitting here moving and talking and living, my body is burning sugar and it's producing carbon dioxide. So that carbon dioxide blood, which is waste, comes back to the heart, and the heart pushes it to the lungs so they can get to the alveoli so you can blow it out. Okay? Now, when you inhale, you take in oxygen. So in the alveoli, the magic is happening. It's giving, the alveoli is giving the blood oxygen and receiving CO2 from the bad blood. So it can get rid of the CO2 and then give the oxygen-rich blood back to the body. With every beat of your heart, every breath you take, that is happening. Okay? So alveolar is the big A. Little a is arterial. That's the blood inside of your artery. Okay? Talking about the arteries. The artery should be full of bright red blood. If it's bright red, that means it's full of oxygen. Okay? Oxygen-rich blood is bright red. Okay? That's why people's veins are dark, right? When you see somebody's veins, especially people who are really light, you can see their veins through their skin, it looks dark because veins are deoxygenated blood. Those veins are returning all of the blood back to the heart, and they dump into the right side of the heart. So all of the deoxygenated blood comes back to the superior and inferior vein cava. That's why it's blue, because it's deoxygenated. Goes into the right side of the heart, gets pumped into the lungs, picks up that good old oxygen, then it turns red, comes back to the heart, oxygenated. That's what's supposed to happen, right? But you're going to learn that don't always happen. And you as a respiratory therapist have to figure out why it didn't happen and fix it, okay? So now, and we said O2 was oxygen, right? All right, so let's put it together. With this being said, I'm going to put these abbreviations so you can tell me what you think it is. P little a O2. What do you think that is? Break it down. Pressure of, that's it. The pressure of arterial oxygen. Because I said that gas exerts a pressure, right? All gases exert a pressure. So now, since this is talking about the pressure of the arterial oxygen, it's inside the body. So what would this measurement be in? Which pressure measurement would this be in? We talked about two pressure measurements, one inside the body and one that we give to the body. So the pressure measurement for pressures inside the body, like the blood pressure, we said blood pressure was 120/80. That's the pressure of the blood inside of the body, right? And so he said it's 120/80. What is the unit of measure? Who can remember the unit of measure?
Mercury.
Millimeters of mercury, good. Millimeters, mmHg. So the pressure of arterial oxygen is written in millimeters of mercury because it's inside the body, right? What about this one? The P big A O2. What would this be? Pressure of alveolar oxygen. So they said you're going to find out what the pressure of oxygen is in the alveoli and what the pressure of oxygen is in the artery. They should be about the same, right? They should be about the same if there's no disease process. So that's how you read this. P, and now P, it says pressure, but it's also known as partial pressure, okay? When you read this, P little a O2 is the partial pressure of arterial oxygen. So this is the partial pressure of arterial oxygen. Okay, that's what this is right here. And this one is the partial pressure of alveolar oxygen. Everybody see it? Y'all see it? So that's how you read some of these things, guys. Now, not only is there oxygen in the artery, but there's another gas inside of the artery. So what would it be if I had P little a CO2? What's that?
Partial pressure,
Good.
arterial carbon dioxide.
Partial pressure of arterial CO2. Okay, that's it. Those two guys are your main two respiratory gases. CO2 and oxygen are your main two respiratory gases. So CO2 and O2 are both your respiratory gases. CO2 and O2. That's gas exchange. Gas exchange only happens, well, I didn't say only. External respiration is gas exchange in the alveoli. Now, not only does this gas have to exchange inside the alveoli, but it also has to exchange at the tissue level, down in your foot, right? Don't your foot need oxygen? Your foot got to get rid of the CO2 that it used and got to be able to get the oxygen. So there's gas exchange at the tissue level and there's gas exchange at the alveolar level, okay? But we'll learn a little bit more about that later, about what that's called, okay? But just know that's where the magic is happening, okay? Gas exchange is the magic. You want that to always be happening, okay? All right. So that is one of your major ones right there, pressure and big A and little a. You want to see that a lot. Let me show you the infamous alveolar air equation. How would I find out what the pressure of oxygen is in the alveoli? And it looks like this. P big A O2, the pressure of alveolar oxygen equals FiO2 times the P bar minus the pressure of water minus the pressure of arterial CO2 divided by the respiratory quotient. That is the alveolar air equation. You're going to know that like the back of your hand when we get to that. This is going to tell us how much pressure of oxygen is in the alveoli, right? It's going to tell us how much is in the alveoli. Now, this is the alveolar air equation. It's not on this test. Okay, I just wanted to show you how these abbreviations, that's why you got to know these abbreviations. So let's look at them right quick before we, I go on. All I want you to know is right now we're talking about is just understanding how to read some of these abbreviations. Big P is the pressure of alveolar oxygen equals the fraction of inspired oxygen times the pressure or barometric pressure, that's the P bar, barometric pressure, minus the pressure of H2O. What's H2O? Water. Because there's water vapor in your lungs too. You got to get rid of that to understand what's just oxygen. Minus the pressure of arterial CO2 divided by the respiratory quotient. Okay? So this is abbreviations in action. Okay? Abbreviations in action. All right. Let's continue on. Any questions on those abbreviations or any kind of abbreviations or what we learned so far?
You said we didn't need to know what they stood for yet?
Yeah, this is the alveolar air equation. You haven't gotten to that yet. I'm just showing you abbreviations in action. But you do need to know the ones I had up there first. The P, the big A, and the little a. Okay? You need to know those. And you just showed me how to read them. That's all you got to do is just put them together. All right. Look at C. C is ATPD. That is ambient temperature and pressure dry. Ambient means outside the body. Ambient is anything that's outside the body. You got ambient air, you got ambient pressures, you got ambient, humidity, all that kind of stuff. Anything outside the body is ambient. Okay, ambient. But that's important because when we start talking about aerosol and humidity and the humidity outside and how it changes when it gets into your lungs and stuff like that, you need to know that. Okay, you need to know what the temperature is. Temperature is very, very important. Temperature changes the pressure of things. Okay, the temperature can change the pressure of alveolar oxygen in the person's body. So if they have a fever, that could change the pressure. Okay, that could change the pressure in the body just by having a fever. So that's why we talk about knowing what the normal body temperature is very, very important. What is the normal body temperature in Celsius? 37 degrees Celsius, which is about 98.6 Fahrenheit. Right? You got to know these temperatures. Very, very important. Okay. The next one is ATPS, which is ambient temperature and pressure saturated. Dry as is if it's no water vapor, and saturated would mean if it is fully saturated with water. Okay. BTPD and BTPS is body temperature and pressure dry or body temperature and pressure saturated. ERV. ERV is expiratory reserve volume. You're going to learn when we get to pulmonary mechanics, what is that? Okay, I'm not even going to really go into that. Just know that ERV is expiratory reserve volume. All right, big E is exhaled gas. exhaled gas, and you don't see that much. The big E just for exhaled gas, we don't really use that much. But the next one we do, F is for what? Frequency. Now, you may also see R or RR for respiratory rate, right? Respiratory rate and frequency are the same thing. Same thing. Frequency is the amount of times a person breathes. Their breathing rate or their respiratory rate is also known as their frequency. Okay, their frequency. Then if we look at the next one is pH. Michaelin, what does pH stand for? I mean, what is the pH, Michaelin?
Hydrogen ion concentration.
Good, hydrogen ion concentration. That determines the pH of the blood. How many hydrogen ions are in the blood determines the blood's pH. The higher the ion concentration, the lower the pH. The lower the ion concentration, the higher the pH. Okay? And look at K. We said gas pressure was P. I was looking for that. I didn't see it, but there it is. P for pressure, or also known as partial pressure. All right. What about BID? Somebody tell me what BID means.
2 times a day.
Twice a day, 2 times a day. So if somebody says, I want you to have albuterol, 5% albuterol BID, that means twice a day. Okay, twice a day. What about TID?
3 times a day.
3 times a day. Okay. Now, BID is twice a day, but also how many hours? Every what?
12 hours.
Q12. So you could say Q12 or BID. Same thing, because there are 24 hours in a day. So if it's twice a day, it's every 12 hours. So it's the same thing. 3 times a day would be how many hours?
3 times. Oh, well, 4.
Not every 4 hours.
3 times a day.
3 goes into 24, how many times?
Oh, 24. 8 times.
8 times. So that'd be every 8 hours, right? You could say TID or you could say Q8. Okay.
I have a quick question also.
Yeah.
I don't see it on here, but QD is once a day, right?
Mm-hmm.
I don't see it on your list, but it's on the paper, so I just want to be sure.
Okay. Yeah. QD is once a day. Q day. Q day. Yeah. If you see something that's not on the lesson plan, it's probably something that you would have to have. You'll see it in the book. Everything's not going to go exactly with the lesson plan. So you got to get in your book and take some of these notes too. But yeah, if you see it and have a question, let me know. All right. What about QID? What is QID? How many times? 4 times a day. So, or how many hours?
Every 6 hours.
6 hours. Q6, right? Could be Q6. 6 times 4 is 24. And then QH is every hour. Some patients are pretty sick and they have to have some medicine every hour. All right, might have to have a breathing treatment every hour. All right, we'll finish up these to you and then we'll take a break. P is talking about VT. We talked about that yesterday. VT stands for
Tidal volume.
Tidal volume. That's the amount of air in which you breathe in and out in normal, quiet breathing. Okay? Normal breathing sometimes is called quiet breathing, resting breathing, all that's the same thing. Okay? Tidal volume is the amount of air moved in and out of the lungs during regular, quiet breathing. How much did we say is a normal tidal volume? How many milliliters or how many cc's do we say is about normal for tidal volume?
500.
500.
500. And then if I don't know how much somebody's is, does anybody remember how to find tidal volume? What was the formula for tidal volume?
Tidal volume equals 3 cc's or either in pounds.
3
You have to convert
cc's.
it.
3 cc's per pound. Make sure you say that part. It's 3 cc's for every pound of weight they are. Okay. Now you said convert. That means if I give you the weight, of course, in kilograms, you'll need to convert that to pounds and then do the 3 times that, okay? But yeah, tidal volume, to find tidal volume would be 3 cc's per pound. What about stat? What does stat mean?
Immediately.
Immediately. They may say, I need you to come to ICU stat. That means go there now. Don't stop by the gift shop. Don't stop by the cafeteria and get your little breakfast. Go handle that first, okay? Handle that first. What about WBCs? White blood count. White blood count are the soldiers of the blood. The white blood cells are the soldiers of the blood, right? Whenever you have an infection or bacterial infection, your white blood count is going to be high because they're out fighting that infection. When white blood cells die, they turn into pus. Okay? So if you have a sore or wound and it's got pus coming out of it, that's dead white blood cells. Okay? What about RBCs? What are RBCs?
Red blood cells. Red blood count.
Good. Red blood count or the red blood cell, right? And the red blood cell is a very important part of the blood. That's the part of the blood that carries the oxygen. The red blood cells have what's called hemoglobin inside of them, and the hemoglobin attracts oxygen. Okay? And that's what carries the blood, the oxygen throughout the blood through the hemoglobin. One way that oxygen is carried is through the hemoglobin in the red blood cells. Does anybody know where the red blood cells are made in the body? Does anybody know where the red blood cells are produced? What part of the body produces red blood cells? All right, I'll let you work on that one. Look at the next one. Now, these are 2 very important notations. A C with a line on top means with, and an S with a line on top means without. Okay? So, for instance, when they say I want to get a CBC, which is a complete blood count with differential, they're going to say CBC with a C with a line on top and then DIFF. Okay? So, it's going to look like this. I want to order a complete blood count, which is CBC. That's a complete blood count. Right? A complete blood count. And if I want with differential, I have to say with. This right here means with. If I don't want it, I have to say without, which is an S with a line on it, means without. Okay? No longer can you just scratch through a line or just say a W, right? I used to do that all the time. When we were still paper charting, I would say, well, he did this with this, and I would put a W or I'd put a /WO for without. You don't use those. This is the correct terminology when charting. You must use a C with a line on top for with to indicate with something, or S with a line on it for without. Okay?
Mr. McCarthy, can you zoom in on the board real quick so we can see what you wrote?
Okay.
Thank you.
CBC is a complete blood count. Now, there's some other abbreviations that you're going to get, like on that list or in your reading, that you need to highlight as well. Like, don't forget it. Everything's not going to come from the lecture. But a CBC is a complete blood count. They want to know all of the different cells that are in the blood. Basophils, eosinophils, and all that kind of stuff, right? And then the C with the line on top means with. S with the line on top means without. Okay? All right, it is 55 after. We're going to take a 10-minute break. Come back at 2:05. I'm going to pause the recording here, and we'll start back up at 2:05. Okay, guys, we're back from break. We're about to get Sydney, the rest of the notes. What you mean the rest of the notes? You mean the note-taking guides? The note-taking guides are in each module. So I didn't send them all out yesterday. I was trying to find my flash drive, but they're in the module. So you can, when you open up that module, you can print it off and take notes from that way. but we'll talk about that at the end of the class. All right. So we're back from break, and we're going to go into the talk about some legalities, ethics. Ethics is very, very important in respiratory. There's a lot of things that happen that are unethical. Okay. A lot of things that happen that you might see and say, wow, I can't believe they did that. And it's your duty to report certain things. But at the same time, your patient has a right to his or her treatment. They can say, I don't want that, right? I've been doing this for years. I'm tired. I don't want to do that anymore. I don't want to live anymore. They have a right to, it's called autonomy. They have a right to not want to do anything else. You can't force your patient to take this treatment or to participate in this therapy that you want to do. They have a right to do that. And so that's what we're going to start covering now. We're going to start talking about your patient's rights, privacy, HIPAA type stuff, and the components of the medical record. Where would you find these different things in the medical record? So let's get started. All right. So what do you do if somebody disagrees or refuses some medicine? So look over these steps. All right. Discuss the proper steps you do if you don't agree with something. What if a doctor says, I want you to go up to the roof with the patient, hold his head over the side of the roof because it gets better air up there? You're not going to do that, right? And not something that's so, outlandish, but there's other things that you cannot agree with because you are a professional, just like he or she is. And sometimes they're wrong, or your patient, and you know that if I do this that the doctor's asking me to do, it may cause harm to them. Now, that's different than weaning somebody to death, right? Once the family has decided, hey, we're through working and the patient has no say, right? That's different than the patient is walking and talking and the patient and the family talking about, let's just let them go. No, you can't do that. If the patient is capable, then they will make their own decisions. Yeah, let me go, right? Or if the patient is incapacitated and he has a power of attorney or something like that, a parent or something like that, a spouse, they will make those decisions. So keep that in mind when you get married, who you marrying, because if something happened to you, your wife or your husband has your right, okay? Whatever he wants to do to you, that's what's going to happen to you, unless you have a written will or power of attorney saying, no, don't let him make none of my decisions if something happened to me, okay? If you don't have that, then he or she will be able to do that in your stead. Now, say you got married to a guy and y'all are not together anymore, but you never got divorced. Now you're with somebody else, been with them for 15 years. You have a car wreck on the way to the store and you're incapacitated. That person you've been with for 15 years has no say-so in what happens to you. Guess who got it? That husband that you never divorced. He will come in and make all the decisions about your care. So if it's a bad breakup, you need to make sure you complete those documents so that doesn't happen. It happens all the time. I've seen girlfriends be at the bedside with somebody and that wife come in and say, nope, he gone. We letting it go. We letting him go. And it could be a girlfriend who's been with him for years crying and no, I don't want to let him go. And he wouldn't want that, but he does not have a written will. He does not have a power of attorney and he never got divorced. So his wife, his estranged wife, has the power. Okay. So you need to make sure you get your affairs in order. If you're married or in a relationship, you need to understand what's going on if something happens, because it just takes a moment for something to happen to you. Okay. You don't have second chances all the time. You can have a car wreck, stroke, anything happen anytime. So you need to make sure your affairs are in order. Now, but if you have a doctor that does something or gives you an order that you don't agree with, then what you need to do is first verify the order. Make sure I heard that right? Somebody told you, the doctor said give them this, this, or that. And you're like, well, he don't, that don't sound right. Let me go check the order, right? Let me go check the order, pull it up, make sure that's what you thought you heard. All right, you can check with the nurse or the pharmacist. Make sure can I give this like this? I thought we couldn't give it like this. Like acetylcysteine is a mucolytic, but you have to give it with the bronchodilator because it could cause bronchospasm. But it didn't have one order. So you would say, hold on, no, we don't rock like that, Doc. We got to have a bronchodilator with that. So you would check with the nurse, the pharmacist, or call the doctor, right? Check with your supervisor. Hold on, we don't do this, right? And then it can simply be, oh yeah, I forgot to put that in. I'm sorry, thanks for catching that, right? But check with them. Call the doctor or the medical director if you're not sure. After you've done these other steps, you don't go right to calling the doctor if everything you don't agree with, right? You have steps that you take. And then if you know it's going to kill the patient, then you cannot do it, okay? Unless the family has decided to withdraw care and the patient is completely brain dead, then you know when you give this treatment, which is weaning them off the ventilator, it's going to kill them, right? You got to do it. I mean, there's nothing you can do about that. All right, okay, Talisha. So that's some of the steps you do when you don't agree with a doctor order, because it's okay for you not to agree. You're not a walking, do what I tell you, right? You are a professional, a medical professional, and you have judgment, okay? And that leads us to some of the ethics and legalities that you'll deal with in the hospital. Please believe me that you can be pulled into court as a respiratory therapist, okay? It's very important to chart and document everything, all right? Make sure you document. If you don't document, it never happened, okay? Write that down. If something is not documented, it never happened. If you don't document it, if I can't go write it down, it didn't happen. So for instance, if Mr. Johnson is a bad asthmatic and he gets breathing treatments Q day or Q hour, and you've been giving him the treatments for the last 4 hours at work, you got a lot of other things you're doing, but you've given him his treatments, right? And he dies. Well, what if you didn't chart the last 2 treatments that you did give him? You gave it to him, but you didn't chart it. Patient dies, found that he died of a massive bronchospasm, right? And it wasn't because you weren't giving him the medicine, it's just because he just was that sick, okay? You can't save them all. But the lawyer, 2 years from now, when they get through with all the, the legalities and all, they can say, well, this is what caused his death. Let me see when the last time he had that treatment. Well, it showed he missed 3 of his treatments. You're not going to remember, oh, I gave Mr. Johnson them treatments. That was 2 years ago. You might not even be at that hospital anymore. You're not going to remember that. And so there's no way to prove you did it if you did not chart it. Okay? You have to chart it. Otherwise, they can say, well, you said you did it, but you didn't write it down, so you're the reason. And they're going to take your license. Okay? They're going to sue the hospital, sue you, and take your license. You can be sued by the patient. So you need to have you some malpractice insurance. Concord will protect you while you are a student. And when you start working for the hospital, they usually have a little minimal policy or plan for you, but you need to take out your own malpractice insurance as well. Just in case you get sued, it'll cover you because you'll be paying for that for the rest of your life. All right, so that's called litigation. They'll call you into litigation, and it could be 2 years from now about something that happened 2 years ago. You don't remember that. You'll be sitting right there in court with all of your charting. The lawyer got a list, a copy of paperwork of all your charting you did. And it clearly shows you didn't give the 2 o'clock and the 3 o'clock treatment. He died at 4 o'clock. But you did give it to him, but you just was too busy, right? You was so busy or so tired of charting it, and you didn't chart it. All right? So that comes to the patient relationships. There was something called the Nuremberg Declaration. Make sure you understand what that is. The Nuremberg Declaration was saying that the patient has rights to informed consent, which means they have a right to know why you're giving them this therapy, and they need to know what's going to happen if I refuse. I have a right to refuse, but you need to tell them, okay, this might happen if you refuse, okay? If the therapy is administered and the patient told you no, you can get sued. So if somebody refuses a treatment, this is your steps. It's 2 steps. Explain to them the consequences if they don't take the treatment, and chart it. That's it. You explain to the patient, Mr. Johnson, I don't want that this time. I don't feel like all that. Okay, Mr. Johnson, you don't have to take it, but just know that it's possible that you can get a little sicker later on and really need me when I'm not close, right? And then we say, okay, that's fine, I don't want it. Then you chart the refusal and you keep on pushing. Those are the 2 steps for charting a refusal. Okay? So the Nuremberg Declaration was put into effect that says the patient has a right to know what you're doing to them. Why are you doing it to them? And what's going to happen if they don't do it? Okay? You don't just walk in somebody's room and start undoing the treatment stuff and setting up equipment and start opening up their little gown and start doing stuff. You got to tell them who you are. I'm Mr. McCarthy. I'm Amen-Ra coming from Respiratory. I got to take a little picture of your heart, or I got to give you a little medicine, open your lungs up. You ready? And let them say, okay, and then you do it. All right? That's how you handle it. And because if you don't do that and you just go in there and doing something, you could give them a treat. They might sit there and watch you give it to them. They've already told the therapist before you they don't want it. And you don't come in and ask any questions. You just come in there and make them do it. You could get sued. Okay? Law and legalities and liabilities are real finicky in the hospital. Okay? Look at B. Improve communications help prevent problems. If you communicate with your patient, you can mess around and dodge a big bullet, right? Respect the patient. Just because they're sick and you got a job to do don't mean you can come in there with an attitude because somebody made you mad on your phone and you're just gonna come in and do what you want to do and come out. That patient is there. You're supposed to be treating all attention on him or her. Okay? Respect their wishes. Okay? Explain in layman's language. Don't go in there talking about your beta 2 receptor needs to be dilated, right? You just say, I'm gonna give you a breathing treatment, help you feel better. Okay? Speak in their language so that they can understand exactly what you're doing. Show kindness to the visitors, okay, and their privacy. Because a lot of times visitors are writing everything you do down, right? They want to know what you're doing to mama and asking you a million questions. They may call a million times at the nurse's station. And so it's easy to get fatigued with them calling you. Okay, and so you can mess around and get a little short with patients or family members, and they remember that. Okay, they may even cuss you out. Then what? You can't cuss them back out. So you have to maintain professionalism. Okay, and that goes about how you act and how you look. Okay, you come in with a certain look, they already expect you to act a certain way. That's why we tell y'all about the dress code and how we should carry yourself in a professional manner at all times. So improved communications help prevent those problems, okay? Then we have to deal about improved records, and that means clarify orders when necessary. If you're not sure, get clarification on that. You don't want to make a mistake. Accurately chart, no whiteout, but even though we don't really do paper charting anymore, there might be something that you have to write down. You don't put whiteout, you do it right? You put a line through it with your initials and then write the correct thing beside it. That's all you got to do. And make sure it's neat and legible so it can be read. And we know that doctors are notorious for writing chicken scratch. But it's not, that don't make it right. They need to make it legible so we don't make that mistake. Okay? Now, as I said, you as a respiratory therapist student are covered by the hospital and covered by the school. Your insurance is covered by the hospital and the school. So that's when you mess around and make a mistake, or if something happens to you, you slip and fall, right, down the steps, or you stick yourself with a needle when you're getting an ABG. Those type of things are covered. You don't have to pay for that, okay? Your treatment is covered by the school and by the hospital. All right. Now that brings us to confidentiality. Very, very big thing in the hospital is confidential privacy. If you tell somebody's information, you can go to jail. All right. Not only will they tell you, slap on the hand, write you up, you could actually go to jail and pay big fines for breaking privacy laws, which is called HIPAA, what we use now, Health Insurance Portability or something, Privacy and Portability Act. We're going to talk about that more in a little while. But HIPAA is very, very important. They do not play about that. So no information about the patient to anyone other than the patient or to the parent regarding a minor patient. All right. Avoid discussions in the cafeteria, elevator, the hallway, public areas, patient rooms. You don't even want to discuss patient information in the patient's room because you don't know who might be in there or what might be what. Okay. The best place to discuss patient information is at the nurse's station or report areas. Okay, write that down. The best place to discuss patient information is at the nurse's station or in report areas. There are a lot of things that have happened that I've seen that makes you want to say something, right? I remember being as a respiratory therapist student. The test results came back from a young man. He was there and his wife. They had children. They were at the room kissing all on each other and, watching TV. You know how you are when we were able to visit people in the hospital. And the young man's test came back HIV positive. But the wife didn't know. And you couldn't tell her, hey, your man got HIV or he got AIDS. Okay, you can't tell her that. He has to tell her that. Okay, if he decides he's not going to tell her, she'll never know. While they kissing all in the mouth and all of that, he got HIV. You know he has HIV, but you cannot tell his wife. Okay, and that on one hand, it's understandable because that's his privacy, right? But on the other hand, it's like she may be exposing or is exposing herself if he ain't telling her to a deadly disease. Okay, that's probably going to be something going with COVID too. The way it's going, they're probably going to mess around and get charges for not telling somebody that you got COVID. Okay, because it's such a deadly disease. All right, so that's just one instance of you have to hold your professionalism and your ethics. Okay, at what point do we tell the patient? That's where ethic committees come in, right? We know this man is having sex with this woman or he's kissing all on her and he know he got AIDS, but ain't telling her. Then you might go and call the ethics committee at your hospital and discuss this, and then they can come up with ways to decide if they want to divulge that information or talk to him to encourage him to let it be known. Okay? But it's not your job to do it. Of course, don't talk about Mr. Johnson's nasty, crusty feet in the elevator, right? Man, did you see Mr. Johnson's feet? They look like bear claws, right? And it could be Mr. Johnson's sister or family member in the back of the elevator you talking about, right? That's a him up, right? You're in trouble if you do that. All right, so just be very careful. People take pictures of people's feet and all kind of stuff, put it on Facebook and showing friends, especially when you're a student and you've not been in the hospital a lot and you're seeing a whole lot of stuff. Famous people, like if there was a big time rapper or singer or something came to Tennessee and had a trauma, got shot, they coming to the med. No matter how famous you are, they going to the med. That's the level 1 trauma center. And I've seen Samuel L. Jackson when he had a car wreck. Morgan Freeman had a car wreck and was there. There have been other high profile people, big time gangsters and stuff like that, who when they get shot up, that's where they go. And so people come in taking pictures and stuff like that. If Michael Jackson or something, it's hard not to do that. Can you imagine if LeBron James was playing the Memphis Grizzlies and he messed around and broke his leg? He's going to the med, okay? And whoever's there gonna want to snap pictures of him, but that's a him up. If you do that, it's privacy, confidentiality, you're in trouble. right? You have to maintain your professionalism. When you are talking about somebody, try to use their initials or description instead of their name, okay? Just try to say, you remember the guy in 13, don't even say 413 or 313, just 13, right? Nobody, I don't know who you're talking about, right? That's how you discuss stuff like that, okay? All right. And always remember, avoid discussions with other personnel. That's just talking about gossiping. Don't get into the field, and as soon as they talking about another therapist, you in listening to it and you talking and repeating it, or stuff like that, because there are things like that that go on. You know, we all grown, and there's gossip out there, okay? You know, you come in, you put your stuff down, you go get breakfast, and they start gossiping about this person or that person. Separate yourself from that, all right? Don't say anything to anyone that you don't want repeated, okay? Now, let's talk about the laws that are governing these things, okay? Private law and tort and intentional tort. Private law deals with definition, regulation, and enforcement of rights in cases between citizen and citizen or between citizen and organization. There are two types of private law, torts and contract law, but all we're going to talk about is torts, okay? Torts. A tort is a type of law, private law. What is a tort? A tort is a legal wrong committed upon a person or property independent of contract. Now, a tort can be intentional or not, okay? Intentional will be straight up assault. You went in there and smacked one of your patients because he grabbed your butt, right? You're going to have some older gentlemen who are in the bed, and some of you pretty respiratory therapists, or if you were a guy, handsome guy, whatever, you may be up on the bed doing a treatment, reaching over a patient. He may reach up and grab a breast or reach around and grab you behind because he's just an old man, right? They do that. Even young dudes. I've seen it happen, right? He does not have a right to touch you like that. He has assaulted you if he does that, okay? But if you turn around and smack the fire from him, then you in trouble, okay? So that would be a assault. Even if it was something that deserved it, right? That would still be an assault. You can't do that. You just report it. All right? So that's intentional. Now, their intentional tort is, there's three types. You got battery, libel, and slander. So there are three types of intentional torts: battery, libel, and slander. Battery is when you touch somebody without consent. This is very thin line because as a man, I have to listen to breath sounds. I come in contact with breaths all day long, okay? But you have to be careful. If you've got a patient that you know is, because you have some patients that are always looking for something to tell on somebody, right? They're always looking for a reason to sue the hospital, or he came in here and touched my breast, or anything like that. If you're a male therapist and you feel that way, get somebody else to go in there with you. Get a female to go in with you, a witness, okay? Because there have been cases where men, therapists, or doctors or whatever have, listened to breath sounds on a young lady and gone a little too far and been caught fondling patients, right? Because patients, it could be a beautiful person or whatever, come straight from the street, got hurt, now they're in the hospital. Well, here they are, completely unprotected. It's nighttime, and here's some pervert therapist or doctor, nurse is fondling this young lady, right? Could be your daughter, your sister, your mama, whoever, wife, right? And so that happens. He listening to breath sounds, but he keeps on doing a little bit too much, right? Or looking under the covers. No reason for him to be around a woman's genitals, right? If he listens to breath sounds, no reason. But it happens, okay? It happens. That's called battery. If she wake up in the middle of you doing it, or somebody catch you doing it, you should report that. If you see a doctor or a nurse doing a little much, or it could be a nurse doing a little bit more with a young man, right? He knocked out and she fondling him. You need to report that. You have a legal obligation to report that. Okay, that's battery. Libel is false or malicious writing that is intended to defame or dishonor somebody. So libel is all it is gossip on paper. Libel is gossip on paper, right? You lying on somebody, but it's on paper. You write a little note about, did y'all hear about such and such and such? Her and her husband did this right here, or she didn't do this to the patient, or she got AIDS, or I heard she was, nobody wants to be around you once you hear about something like that. You don't believe everything you hear, but if you're going to think twice about being around that person if you know if somebody writes something like that about them. So that's libel, right? That's intentional. And then slander is spoken. The same defamation, but you say it, right? You're slandering somebody. You don't like that therapist who you are falling behind. They're supposed to give you report, right? But every time you come in, you say, every time I come in, she don't never have the trach care done, or my patient's always nasty when I get to them, or she never changes the water. She don't know what she's doing, right? So when other therapists hear that kind of stuff, they don't want to follow behind you. So when they get there and get their report and they see who they follow, oh, I'm following her. I heard she's such and such and such and such, right? And that's bad, guys. That puts a bad environment in which you have to work every day. Stay away from it. That would be slander. Now, we said that there were two types of private law, tort and contract law, but we're only talking about torts. But there are two types of tort, intentional and negligent, right? And the intentional has three subcategories, which are battery, libel, and slander. So now let's look at the second type of tort, which is negligent tort. You didn't really mean to do it. It just something happened because you didn't do what you were supposed to do, right? You were supposed to give Mr. Johnson his last treatment, and he messed around. You didn't give it. He messed around, had an asthma attack, and died. Well, you didn't want him to die. You just wanted to eat your breakfast first, right? You didn't really want him to get hurt. It's just because I didn't feel like it. My feet was hurting, right? I've been calling me all day. I've been running all day. I ain't going. He be all right. He don't even want nothing. If you talking, you can breathe. How you can't breathe when you talking, right? I heard people say that. You know what I'm saying? He talking about he can't breathe, but he talking. You don't know what the people feel like, okay? So you cannot do that. But if you do that and something happens, that's negligent on your part, okay? That's negligence on your part. Now, the negligent tort also has two subcategories. Now, let's see what a negligent tort is. It's malpractice, carelessness, or failure to act with due care on the part of the professional. You just refuse to do the treatment because you didn't feel like going. They called you from 5 north and you way on 5 south, and I don't feel like walking all the way over there. When I get over there, he gonna be on the phone laughing and everything. He can breathe. I ain't going over there. He call every 5 minutes, that type of thing, right? Because you got patients that are worrisome, okay? That's just true. So if you don't do it, they just be that one time you decide not to do it, something gonna happen to them, and then there you go, okay? Negligent. Now, the negligent tort has malfeasance and negligence. Malfeasance is execution of an unlawful or improper act. Execution of an unlawful or improper act, like taking the patient's pain medicine, right? That's malfeasance. If the nurse said that they gave him the pain medicine, but took the pain medicine for herself or himself, every time they kept doing it. Every time I work with you, the patient always hurt, right? You're not really, but you're showing that in the MAR, you're giving the meds, you're giving his medicine every hour or every 4 hours, but he seems to always be hurting when you on shift, right? They notice stuff like that because they got people that's watching stuff like that. Or every time I got this man behind you, he always is short of breath. He always working hard. Are you giving him the medicine or not? Or you just going to get the medicine out, scanning his bag, scanning him, and then going to sit down and just charting anything, and not giving them the medicine. It happens. A lot of times it's because therapists have so much work, because staffing might be low, and so you start being negligent. You got to be careful, okay? And then negligence is reckless disregard for the safety of another. Reckless disregard for the safety of another. That's just negligent. You know Mr. Johnson is heavy. He always trying to get out the bed, but you lift the bed rail down. He got on your nerves. Here, take this, and just leave him where he just know he gonna fall when you leave. You know what I'm saying? Or whatever. Something spilled and you just left it there and didn't say nothing at all. Okay, that can hurt somebody if they come up behind it. All right. All right. Man. All right, so the next thing would be reciprocal patient rights. Basic principles of healthcare ethics. The basic principles. The patient has a right to autonomy. They got a right to choose what therapist they want in their room. If they say, I don't want her, she got a bad attitude. Every time she come in here, she on her phone, stuff like that, right? They got a right to say, I don't want that doctor. I don't want that nurse or MA or whatever. You can be fired from a room. I've been fired from a room. Patients are sick. You don't know what they're going through. Sometimes they just jealous of you, right? It might be a patient there who has a child or a son that's your age, or a daughter your age that ain't doing nothing with her life. And here you are doing what you're supposed to be doing and all that. Oh, she thinks she's good and all that. I don't want her in my room, right? It happens. It happens, okay? So they have autonomous choice. They can choose who they want to help them. They have a right not to be harmed, right? No matter how they may act, they have a right not to be harmed. They have a right to fair and equitable treatment. They don't want you. They got a right to get the same amount of treatment that you gave the rich man down the hall. The guy who's in the ER who stinks and is homeless got the right to have the same amount of treatment. Okay, the same level of treatment and care. All right, autonomy. Patient personal liberty and their right to decide their own course of treatment. Have informed consent. Educate the patient so that they'll be able to make their own course of treatment. You gotta let them know what's going on, Mr. Johnson. You got COPD. Your lungs are pretty damaged, and this is the course of treatment that we want to do with you. You got to be able to tell them so they can say, "No, man, I'm tired. I've been smoking. I'm 90 years old. I don't want to go through all that rigorous testing and therapy. It got me walking on a treadmill and all. I don't want to do all that. Just leave me alone." They have a right to that. That's their autonomy. Another term is veracity. Veracity. That binds the healthcare workers to tell the truth. Veracity binds you to tell the truth, right? You know that your coworker hasn't been seeing this patient, and she been sleeping, or he been sleeping and been, not doing what they supposed to do. When they come down to you and they ask you about it, you're bound to tell the truth, because the patient is being harmed. If they're not getting their medicine and their treatments, they're being harmed. I thought I wasn't recording. All right. Benevolent deception. Benevolent deception is when the truth is withheld from the patient for their own good. You hold the truth for their own good. Now that's a thin line, because it's like, I ain't supposed to lie, but at the same time you're telling me to lie, right? It's just a really thin line. For example, when I worked in trauma, I had a young lady who was about 22, 23, who was about 7 months pregnant and had a massive car wreck in Memphis. She had a 8-year-old son in the car with her. And she was damaged pretty bad. She was, almost unconscious, right? But the firefighter said when they were leaving the scene, they were doing CPR on her 8-year-old son. And they flew her to the hospital, she's pregnant. And she was waking up in the hospital. Where's my son? How's my son? and he was dead on the scene. But you're not gonna say, well, man, he dead, right? In the middle of trying to stabilize her, you're not gonna say, well, ma'am, he didn't make it, right? Your son is dead. You never would have been able to treat her, okay? So he's okay, he's okay. We're gonna deal with him. Let's just get you straight, right? That's what we had to do. That's called benevolent deception. Benevolent deception. Then non-maleficence or malfeasance obligates the healthcare worker to avoid harming the patient and try to prevent harm wherever possible. So just watching yourself. You're just somebody who's always double checking to make sure I'm not hurting you. Mr. Johnson, does that hurt? You okay? You sure you're okay? Or let's put this rail up and make sure you got those little skid socks on because you're okay now. You're all right? You know, that's just making sure that the patient is trying to avoid that the worker is avoiding harming the patient wherever possible. Almost done with the terms. Then beneficence. Beneficence is healthcare workers go above and beyond doing no harm and actively contribute to the health and well-being of their person. So this is somebody who just goes above and beyond all the time, which you won't have much time to do. But this is after you gave the breathing treatment, or you got the ABG, or you did some postural drainage, some hyperinflation therapy, or some education to the patient. After that, you pull the table up to him because his lunch came in, right? You pull the table up, open it up, put a little salt and pepper on his rice, feed it to him, little stuff like you going above and beyond, right? That's not your job to feed a patient, but to make sure that they're happy, right? The well-being. Thank you. You know what I'm saying? Just they remember that kind of stuff forever. Okay, that's beneficence. Just being like an angel to the patient. And then, of course, confidentiality. Don't talk about the patient in areas where others can hear you. Use the report room to discuss patient information. Best place I told you was the report room or the nurse's station. Okay. Now, on that note, before we go into the charting, I'm going to show you a quick video of some confidentiality thing. It's kind of like a little funny video about confidentiality. Now, I won't be able to record the video, but you can go back. If people who are online right now, you'll have to play the video yourself, which is in the module. But as I'm recording, if I show it, then the YouTube will flag it and I won't be able to record none of my lecture. Okay, they'll try to take it out for rights. So I'm gonna stop the recording and show you that video. Then we're gonna take another break. After that break, we're gonna come back into charting, talking about where I can find what in the charting, and that should be pretty much it for 210A. Okay, so I'm gonna pause right now and show you that video, and then we'll record again for the charting part. Those who are watching me now later on, you can go to the module itself and but just click the one that says spoof, HIPAA spoof, and watch it yourself, okay? It's nothing you're gonna be tested on. I just wanna show it to you. All right, so I'm gonna pause the recording. So that was a little quick, funny video about privacy. A lot of people didn't know that even if you have a chart at the hospital, you can't just go look in it, okay? If you work at a hospital and now you know, a respiratory therapist at a hospital, but you know you had some labs at that hospital or some kind of test done, you can't just go type your name in and look at your chart because it will pop up because you got access to the system. But if they catch you doing that, that's a HIPAA violation, even if it's your chart. There's a proper channel for that. You have to go by medical records and request a copy of your chart. And then you can get it and look at it like that. But you can't just go look at your own chart, okay? And then we also saw that doctor erasing something out the chart, right? Even though he couldn't do it, you don't do that, right? That's not nothing you do. And so that was just something to show you that it's very important, even when it's your own chart, there's still processes in place that you have to follow, okay? All right, we're going to take a break now. It is 2:52. or 2:55. Let's just say it's 55. Come back at 3:15. We'll take a 20-minute break. Come back at 3:15, and we're going to finish up RT 210A. All right, guys, we're back from our 20-minute break. It is 15 after. We're going to finish up the lecture with the components of the chart, where to find this information. And then I'm going to put up a sample exam and have some questions up, give you some time to work on them, and just ask each individual person, what you get for number 1, what do you think for number 2, stuff like that, and show you what an example exam will look like on tomorrow, okay? The homework for tonight has been put into the module. It is homeworks 2, 3, 4, and 5, and you have till 1 p.m. tomorrow to complete it, okay? So not just tonight, but you have till the start of class to submit it to me, because at 1 o'clock, I'm going to put the attendance in, okay? So you'll have till 1 o'clock to submit that the same way you did this homework from last night. Let me see. And the note-taking guide for the next section is up on the module. So RT 210B, which is cardiac AMP, is now open in Canvas. I got that module open so you can be looking at it, perusing it, looking at the PowerPoint, start your reading, stuff like that, so you can be on top of it. So Thursday, when we come to class, that's what we're going to start on, okay? We'll take the test tomorrow. You're going to go home, start studying, start reading, and Thursday, don't forget, Thursday is the Omega Group's availability to come in for the live lecture. If you are wanting to come do live in-person lecture on Thursday and you are in the Omega Group, you can come. Today was for the Alpha Group and I only had 2 people show up, okay? And that's fine, you know, however you want to do it. Tomorrow, both groups will show up because tomorrow is the exam, okay? You will show up at your design time, your designated time, okay? Come in, take your exam, and we're done, okay? Go home. And then Thursday, the Omega Group, if you want to come in person, you can come from 1 to 6 and be here and take part in the cardiac AMP lecture live and direct, okay? All right. Components of the chart. Now, charting has 4 basic parts, okay? The problem, we use what the POMR. The POMR is the technique we use in charting, and it's the problem-oriented medical record, okay? You have 4 parts. You got a database, a problem list, you have a plan, progress notes. Yeah, I think that's, yeah, the progress notes, okay? And this is how it's broke down. In the database, it contains the information of a routine nature, general health history, physical exam results, results of diagnostic tests like ABGs and X-rays, CTs, MRIs, any kind of diagnostic test like that you'll find it's made into the database, right? That's the database of the POMR, which is a problem-oriented medical record. This is the record, okay? Then you have the problem list. You have a section that consists of the problem list. That's what's wrong with you, right? Something that interferes with the patient's physical or psychological health or ability to function. So what's the problem for the patient? Is it a stomach issue? Is it a cancerous issue or whatever? That is the problem part of the chart. Lets us know what is actually going on. Then you have a plan, right? The course of action to correct those problems from the problem list, okay? When I find out what the problem is, I have to set in motion a plan. How do I plan to deal with it, okay? Then I have what's called progress notes. There's a progress notes part of the medical record, which contains the findings, subjective or objective, assessment plans, and orders from the doctor. So subjective would be stuff like, I can't breathe, my heart beating fast, stuff like that. Those are things that the patient or patient's family can tell you what's wrong with the patient. And objective would be stuff that you found from the test, right? Or that your medical terminology of what's wrong. So for instance, a patient says, I'm short of breath, I can't breathe, my breath hard to catch, right? Those will be subjective assessments or findings. But then when you write it down, you say the patient is experiencing dyspnea. Dyspnea or dyspnea is shortness of breath, okay? And so that's something that you formulated by you looking. Subjective is what they're telling you is wrong, okay? So the progress notes will continuously tell, today the patient said he or she was feeling this way or feeling a lot better, right? Getting better, walking around more, whatever. It's just some daily findings, and if there's new orders that the doctor did, you can find that in his or her progress notes. Every day, the doctor will put something in the progress notes to show how the patient is progressing along every day. All right. The format for the progress notes is we call the SOAP method. The SOAP method. Okay. So like I said, subjective is S, O for objective, A for assessment, and P for plan. That's the form we use, the SOAP method. We get the subjective information obtained by the patient or the relative, right? Then the objective information is based on the caregivers, like me. Somebody's taking care of them. The physical exam, when we actually do a physical exam, do some diagnostic or x-rays or other laboratory tests, that gives us objective information, okay? That's the difference between subjective and objective. Then we have an assessment that refers to the analysis of that patient's problem, right? Once I see or you telling me what's wrong and I'm finding out what's wrong, now how do I want to deal with it? How do I want to tackle it? When I'm a respiratory therapist, you have a toolbox. Starts from little things all the way from a little nasal cannula all the way up to a life support respirator or ventilator. And you have to decide, where do I want to start, right? And you need to start not too much, but not too low. You need to have a good plan, right? A good assessment of what's going on. This is what's wrong with him. And out of what he said and what I see, this is what's wrong. Now, after I find out or I decide this is what's wrong, then I have to have a plan to tackle it. How am I going to take action to be taken to resolve that problem? That's the SOAP method, okay? That's the SOAP method. All right, SOAP. Now, the components of the chart, where this is going to help you understand where you would find certain things in the chart. Now, the chart is based off, and of course, it's electronic now, but even in the electronic MAR or the EMR, electrical medical record, it has an admission record, which tells the date and the time that you were admitted to the facility, right? Patient presented to the ED on January 4th, 2021 at 6:29 p.m. Also has their birthday, your social security number, your address, telephone number, next of kin, and your insurance information, right? Now all that is in the admission record, okay? Those two things are in the admission record. Then you have the physician order section. Physician's order section is all the orders that the doctor has put in. I ordered some oxygen, ordered some nutrition, ordered some CPT, ordered the ventilator, ordered some physical therapy, whatever the doctor has ordered, all that is in the orders. You have to check the chart for orders. You do not go and just start doing therapy. You have to have a physician's order in order to start touching or dealing with any patient, okay? Most hospitals have what's called a therapist-driven protocol, okay, in which the doctor already orders the protocol, right? And then you follow the protocol by different things. Like, I know if I see this, I can do that. And if I see this, I can do this. You already know what you can do without calling a doctor for every single thing. You just follow the protocol, okay? That's if they trust respiratory. Now, if the doctors don't trust, you don't have a good rapport with the physicians, then they're going to request that you call them for every single thing, okay? Now, so that orders, that part of the chart is called the orders. Now, physician orders is very important. All of the physician orders must contain the date, the time, and the doctor's signature. We'll see that on the test. Physician orders must contain the date, the time, and the doctor's signature. If it doesn't have the date, the time, or the signature, it is not valid. It is not a valid order. All right, then we have the progress notes. We talked about that earlier. What the progress notes is, every time the patient is visited by the doctor, the patient's progress is recorded. Simple as that. Every time he or she goes in and check on Mr. Johnson, whatever Mr. Johnson said or however he's feeling or whatever, he'll put that in the progress notes. Then you have a section called the H&P, which is history and physical. The history and physical examination is also known as the H&P, right? H&P. And this is when you're going to get all of the information you can stand, okay? This is going to tell you all about the history of the patient from when he was first diagnosed 20 years ago, and the first surgeries that he had a long time ago, and all those things will be in the H&P. You guys, when you get to 220 and you start visiting patients, have to do chart exams, right? You're going to have an assignment every week to have to do a couple of chart exams. You're going to take a patient and you got to fill out a whole lot of information about it that's on the sheet. You're going to find that information in the patient's H&P. You might have to peruse into his data. You might have to look at his lab exams and stuff like that to answer some of the questions on your paper, but that's in 220. So the H&P is a history of the patient that's obtained from the patient or relatives when the patient is admitted. How long you been smoking? When did you get that trachea? You had bypass. See that scar on your chest. When did you get that? Oh, that was 1985. Okay, all that stuff is in the H&P. Okay. And also the H&P has the initial physical performed by the attending doctor. Okay. And that initial physical is a head-to-toe assessment of the major organ systems. So, for example, the H&P not only has all the history and physical of the patient, but at the end, it's going to start with head. Whatever the doctor found about the patient's head, he's going to write it, or she's going to write it. Neck, anything about the neck, they're going to write. Chest, anything about all the organs in the chest, they're going to talk about. You know, abdomen, pelvis, digestive system, skin, all of the systems and stuff, they're going to talk about from head to toe. Scars on the left leg, bed sores on the right butt cheek, whatever it is, they're going to talk about it, because what's important is because they need to know, did this happen at this visit or this already was on him when he got here? Okay, they do a major up and down to make sure that the family can't say he didn't get that bed sore till he got to y'all's facility. And you say, no, ma'am, when you look at the history and physical upon admission, that was already documented that he had a large sacral wound the size of my fist when he got here, right? Or he had pneumonia, or he had whatever cuts and bruises on his body when he got here. So that way the hospital is not liable for anything that shows up later. But if it's not charted, guess what? It did happen there. If the doctor doesn't do a thorough exam and forgets to notate that sacral wound, then guess what? The family can say he got that here, and there's no proof to say he didn't. Okay? So it's a head-to-toe assessment. Then you have nursing data. Nursing data, which would also be nursing and respiratory. Nursing and respiratory data That includes nursing and respiratory notes and assessments and records, okay? Anything that we decided to put in there or that's been going on with the patient, the stuff that we see, we put that there. We do ABGs or bedside spirometry, stuff like that. Any kind of diagnosis stuff that we do, we'll put that in that section of the chart, okay? Pulmonary function tests, stuff like that. That will be in that part of the chart. Then you have what's called the graphic record. What does the graphic record have? It has contains the running pulse, the temperature, respirations, blood pressure, urine output, oral intake, daily weights, right? So I'm going to put beside this vitals. Right? The graphic record, also known as the vitals. Patients, and a lot of times you can do this now that it's electronic, it can give it to you in a graph form. It can show you what the pulse has been for the last 3 or 4 days and a bar graph, right? Or a line graph. It'll show you what the temperature has been ranging. Like for the last week, he's been holding at 97.5, 98, but then the last couple of days, he's been spiking, right? They can look at that and see the last couple of days, his fever has been inching up, right? So that gives us trends and shows us the vitals, the respirations, his blood pressure. Has it been trending up? Has it been getting better, right? Urine output and oral intake. In and out balance is very, very important. In and out balance is very important because if your patient is overloaded with fluid, then that can cause respiratory issues. If the lungs are full of fluid, he can't breathe, right? And you need to know that, man, he took in 3,000 mLs of fluid last night, but only peed 100 cc's. So he's 2,900 plus, right? That's what fluid has to go somewhere. And that might be why he can't breathe. So then you would converse with the nurse and say, hey, can we give a little Lasix or a diuretic, right? And that'll help pee some of that fluid off of him. And then that might fix your problem, right? So it's very, very important to know the intake and outtake, the daily weights. The doctor wants to know if he gained 5 pounds overnight. If he did, that's fluid. Fluid. And that causes problems. Okay? It causes problems. You get fluid build up around the heart, which is congestive heart failure. Fluid develop in the lungs, which is pulmonary edema. And it can get third spacing, where it can be so much fluid in the arms that you can push down on the skin and water come out. Okay? If their kidneys are not working properly, they're not flushing that water out. There might be a kidney issue. So that's why you have to know so much. Okay? It's not just stop by, here's a breathing treatment for you. Right? You have to know everything about your patient, even other organ systems. All right? Laboratory results. If I want to know what the x-ray said, or the CT said, or MRI, PET scan, ultrasound, I'm going to look in the laboratory report section, okay? Because you're going to have stuff on the test and say, where would I find this, or where would I find that? Matter of fact, it might have been on the homework last night. What section of the chart would I find this or that, right? This is how you find it right here. Operative data. That's going to say all his informed consents, his operation. He had a surgery on his gallbladder. His anesthesia went well. Did he sign a consent for anesthesia? All that kind of stuff will be found in the operative data section. And then the big one is the medication administration record. The MAR, M-A-R. The MAR is also known as the medication administration record. Right? That lets you know every medicine that was given, who gave it to him, what time it was given, and how much it was. Okay? Once you scan that medicine and scan that patient's wristband, it puts it in the MAR that you gave it. Okay? So if I want to know who gave medicine 2 weeks ago at 2 o'clock, I can look at the MAR, go back to that day, and say, oh, Mr. McCarthy gave it to him at 2 o'clock in the evening and gave them an albuterol treatment. Up with them their whole record of them being there, okay? Whole time they're there. Now, ancillary services is which one I can't stand, because this is an old I always take this out. We are not ancillary. Ancillary means other people, right? Respiratory is not considered other people, okay? Respiratory is very vital in keeping you alive. We run the ventilators. We make sure that you're breathing. We make sure that your lungs are clear. That's not the same as physical therapy. Physical therapy is wonderful, right? But it doesn't keep you alive. Being a medical assistant is a wonderful profession, but it doesn't keep you alive, okay? Respiratory, just like nursing and doctors, keep you alive. We introduce the tube down your throat when you can't breathe, called intubate, and breathe for you. Nobody do that but us, okay? Nobody can do that but the doctor or the respiratory therapist, okay? So that is very important. So ancillary would be occupational therapists, speech therapists, and physical therapy. That's ancillary, okay? Those are any kind of reports that they have. Mr. Johnson was able to take 20 steps today, right? That's a good progress. That's wonderful. I'm not knocking the other professions. I'm simply saying we're not like them, okay? We keep you alive. And without respiratory, you die, okay? If I tell you what, when COVID hits and people are essential workers, PT, ST, and OT at home, okay? You are essential. When they get down to the point where they only can have people who got to be there, it's respiratory will be there no matter what, okay? You will be there. So don't think you're going to get off when they start talking about essential only. That's you. Physical therapy, they can do without, right? They can do without this walk or this turn and this rubber band action, right? They can do without that if they have to. And then finally, a discharge plan. Believe me, from the moment you get to the hospital, they already figuring out when you're going to be gone because they're paying money. Insurance only pays so much for you to be there, right? And so if you are there longer than your estimated length of stay from Medicaid or Cigna or Blue Cross or whatever your insurance says, this diagnosis, he should only be there 2 weeks. They're going to be trying their best to get you out of there in 2 weeks. Otherwise, if you're there 3 weeks, that's that last week, they're paying for it. Insurance is still paying. Insurance.
I'm trying to turn it on.
All right. Once that 2 weeks is over with, insurance says we're not paying y'all nothing else. So the hospital has to eat all of that cost and then bill you about it later. Okay. So the discharge plan is okay. Now we got him in. Let's figure out what we're going to do, how we're going to treat him, and how we're going to get him out, either to a skilled facility, a long-term care facility, a nursing home, or home. Okay. That's why they have caseworkers and stuff like that. They're getting you out of there. They get them in and get them out. Okay. All right. That is the end of RT 210A. This was the kind of little foundation about terminology and stuff. It was the easy thing, right? It was kind of boring, but necessary. Okay. Thursday, we will get into this heart. You're going to know everything about this heart that you thought you never learned. All of the components, all of the chambers and the little valves inside of there. You're going to learn all of that. The way blood flows through it, you're going to memorize it. Everybody here is going to have to recite that to me, which you're going to be able to do. It's not hard as you think, and it's fun. When you start learning about what's really going on in your heart, you will have a better appreciation for what you put in your body. Okay? All of them chitlins and fried chicken and all of that, you ain't gonna do that no more once you start learning about this heart. Okay? Fried food and French fries and all of that, cut that out. Okay? Cut that out. All right, so at this time now, we're gonna start, I'm gonna go over some review. We're gonna just do some review questions. You can use your notes, but try not to. If you've been studying and reading, you may not have to use them. All right. I'm going to put up some questions. I'm going to stop the recording because I can't record Yes, I can. Yes, I can. I'm gonna record. Don't worry about it. But I'm gonna put up some questions, and it will be some questions that will be kind of like the questions you will see tomorrow. Okay, like a sample or alternate exam. I don't do this for every exam. Every now and then I will, but this will give you a kind of taste of what our test will look like and be like. Okay, or at least for tomorrow. And so you'll go ahead and I'm gonna put them up, and then I'm gonna give you like a couple of minutes to look at the first couple, and then I'll call your name. You tell me what you think for number one or number two or whatever. Okay, don't just yell out the answers. Wait till I call you and you tell me out loud what you think it is. Okay, we're not gonna do the chat because that's too much for me to look back and forth to the chat. I'm gonna call your name, like I'll say, for instance, Courtney, what you get for number two, and you'll tell me A, B, C, or D. Now, instead of saying A, B, C, or D, read the answer, because A and B and C, they sound the same, especially over online. So I might thought you said D and you said E, right? So just tell me the answer, the word, okay? And it's okay to be wrong. This is the time to be wrong. So don't be, I don't want to say it. You can't be timid as a respiratory therapist. Make the decision and roll with it, okay? Right or wrong. All right. All right. Let's look at 1, 2, and 3. Everybody look at 1, 2, and 3. Everybody do 1, 2, and 3. Then I'll ask you, and then you can, if you agree or disagree or whatever, and we'll go from there. Everybody look at 1, 2, and 3. You can't see it? Oh, okay. Sometimes it does do that. It's still blurry? Okay. Sometimes it gets blurry, guys. I don't know why it does that, but try your best to look at it. Huh?
We can't see the
I
rest
can see
of
1 and
3.
2. I can't see 3.
Yeah, well, do 1 and 2, because if I make it smaller, it gets blurry.
Okay.
Can y'all see? Can you see? Is it blurry?
Yeah, it's still blurry.
Yeah, that's what I'm saying. So I'm gonna put it back up. How does 1 and 2 look?
That's fine.
All right, do 1 and 2. And we're gonna move on. We're not gonna be 5 minutes on 1 and 2. Okay, we're gonna boom, boom, and we're gonna roll out. All right, so when y'all look at this, all you're doing is look at the question and try to figure out the answer. Don't try to write the questions down and all. You don't have to do all that. Just look at it, write your answer A, B, or C for 1 and 2, and then I'll go around. Okay. All right, number 1, normal body temperature, Brittany, is what? C, 37 degrees Celsius. 37 degrees Celsius. Number 1 is C. Number 2, the best place to discuss patient's condition, Kiara, is where? I thought Kiara was with us, huh? All right, Charisma. Number 2, the best place to discuss patient condition is where?
Only in the report area.
In the report area. C, report area. Good. All right, let's look at 3 and 4. Number 3, cold blue means what? Cassidy.
C, cardiopulmonary resuscitation is needed.
Good. Cardiopulmonary resuscitation is needed. Number 4, if you have an order for therapy that you don't agree with, Christian, what should you do?
Is it C, call the chief of staff?
No. Chief of staff is,
D.
that's the president of the United States, right-hand man.
No. Or is it tell your supervisor?
Tell your supervisor. Out of those choices,
Okay.
that's the best one to do. Tell the supervisor,
Okay.
hey, I don't agree with that. And then you go further. You know, if that don't work, go to the doctor, right? All right.
Okay.
6 and 7.
You skipped 5.
Did I?
Yeah, you
Okay.
skip 5.
5 and 6. And I may not do them all. I'm just going to do a few. Number 7. All right. Which of the following list priorities of therapy and respiratory care in the correct order? Sydney, what you get for number 7?
Is it E?
E, let's see. CPR, CMV, ICU, ER, post-op. All right. So we know CPR is first, right? So the only 2 choices it could be is either B or E. Okay.
Yeah.
So CPR and ER, no. So yeah, the answer is E, CPR, CMV, then go to the ICU, then to the ER, and then any kind of post-op care, oxygen and humidity. Okay. That's how you would do that. That's your priorities. Good. All right. Let's look at 8 and 9. All right, number 8. Which of the following are responsible for clinical functions of the medical policy of the RT department? Stephanie. I ain't call you yet, did I, Stephanie? I don't think so. Stephanie, number 8. Which of the following, who is responsible for all the clinical functions of the RT department? Stephanie, you there? I think she's at work too, though. So okay, Michaelin, number 8. Who's responsible for the medical policy of the RT department?
The medical director.
Medical director. Excellent. Number 9. The term anaerobic means what, Maria? Number 9. Existing without air. Good. Good. Existing without air. Good, Maria. All right. Let's look at number 10 and 11. Number 10 will be Lori, and 11 will be Kelsey. But everybody work them just in case they're not right. 10, Lori, and 11 will be Kelsey. So give everybody a moment to do it. And then I'll read the question. All right, Lori.
10 is A, fever.
Hey, good. Febrile means they have a fever. They have a fever. What would blue color mean? What word is for blue color? Anybody?
Cyanotic.
Cyanotic. Cyanotic. That's a low oxygen. They become blue, right? Cyan. Cyanotic. What would the word be for without fever? Anybody?
Afebrile.
Afebrile. Good. You just put the A in front of it. Afebrile. And then who can tell me what uncontrolled bleeding is?
Is it hemolysis?
No, but it's close. That's close. When somebody is bleeding uncontrollably, that's called hemorrhaging. Hemorrhaging, right? All right. Number 11, Kelsey, bronchoscopy. What would that be?
Visual examination of the airways.
Excellent. Visual examination of the airways. All right, 12, 13, and 14. Let's see. That would be Courtney, Christian, and Cassidy. Courtney, Christian, and Cassidy. 12, 13, and 14. All right, so Courtney, tracheotomy is what?
Incision into the trachea.
That's the incision, right? Tracheostomy is the hole. The hole in the trachea is the ostomy. The cutting of that hole is the otomy. All right, number 13. Who I say, Casey?
You said me, Christian.
Christian, okay, Christian. Retrosternal space is found where? Retro?
Above the sternum.
Oh, what's retro mean? Above the sternum would be suprasternal. Suprasternal. That's above.
So is it D behind the sternum?
Yeah, behind. Retro. Something that's old is a retro, like retro Jordans, right? Those are old Jordans,
Okay.
right? Retro or throwback jersey. Retro jersey with some old player, right? It's old.
Okay.
Or behind, you know, something that's behind or in the back. Okay, good. All right, 14. Who I say, Cassidy?
Yeah, you said me. B, rapid respiration.
Rapid respiration is tachypnea, because pnea is breathing. Tachypnea or tachypnea is fast breathing. Good. Let me see. I think we are now at Charisma, Brittany, and Kiara for 15, 16, and 15 and 16. Brittany and Kiara. So Brittany will do 15 and Kiara will do 16 if Kiara is back. Kiara, you with us? She in the chat. Oh, she can't talk or something. Oh, okay. Okay, so you Brittany. I don't know why I keep thinking you in here. I'm yelling at you. All right, so Brittany, hypertrophy or hypertrophy is what? Underdeveloped? No, not underdeveloped. Hypertrophy is, Say it again. Hypertrophy, what, somebody tell me what hypertrophy would mean. It's hyper.
Increase.
No, look at
Overdeveloped.
overdeveloped. Yeah, number 15, overdeveloped. Hypertrophy is overdeveloped. All right, Kiara, if you can tell, write it in the chat if you can't talk, Kiara. 16, the root cyan means what, Kiara? C, blue color, good. Blue color. All right, let's look at 17 and 18. That will be, go back to the bottom, Shatara and Talicia. Shatara 17, Talicia 18. 17? Okay. The root myco refers to what, Shatara? Myco means what? Myco. Does that help you? Can you see it now? No, somebody tell what myco means.
Fungus.
Fungus. Myco means fungus. Myo means muscle. Don't get them too confused about myco and myo. Myco is fungus, like mycofungin. That's some kind of medicine that we give called mycofungin. Okay. Myco is fungus. Number 18. Talisha, the AARC is what?
Organization for Respiratory Care Practitioners.
Good. Good. American Association for Respiratory Care. It is an organization for respiratory care practitioners. They're responsible for what? Anybody?
Promoting respiratory therapy.
Promoting the profession. They give out the AARC magazine. They give us the guidelines to respiratory care, and they fight for you in Congress. Right? All those things AARC does. All right. Sydney and Stephanie, 19 and 20. Little math. 19 and 20. So Sydney, I want you to tell me, calculate the change from centigrade to Fahrenheit. So that means Fahrenheit equals what? Which one of those is correct? That question is asking what is the formula for Fahrenheit?
I think is it A?
Fahrenheit, let me see. I got them wrote down. I forget myself. Number 19 is A. Good. 9/5 times Celsius plus 32. That's Fahrenheit. Okay. 9/5 times Celsius plus 32. That's the formula for Fahrenheit. You may get something like this, or they may give you a centigrade and tell you to calculate it in Fahrenheit. All right, so make sure you're studying. And finally, number 20. This is for everybody. Now, who did I say this was? Michaelin or Stephanie? Okay, anybody. If a patient weighs 170 pounds, how many kilograms would that be?
B, 77.2.
Yeah, number 20 is B, 77.2 kilograms. And she did that by doing 170 divided by 2.2. Divided by 2.2. All right. All right, guys, that is an example test. If you feel like you got most of those answers right, then you're good for tomorrow. You should be fine. This is the easiest test you're going to have. Okay. This is just kind of getting some things out of the way because I will be using this terminology as I go. Tachypnea and bradypnea and retro and superior and supra, inferior, stuff like that. I'm going to be using those terms. Tomorrow is the exam. Make sure you guys come at your designated time. If you're in the alpha group, you come at 1 o'clock, not any time between 1 and 3. You come at 1. And if you are in the omega group, you come at 4, right? Now, I did say it didn't really matter if we don't have a lab. Now, the days that we don't have a lab, I don't care what time you come in that time frame, okay, to be honest, because we don't have a lab. Only time it matters that you come is when I have to teach you a lab. Because when I have to teach a lab, I can't be teaching and I'm in the middle of it, then somebody else come in, 2 or 3 more students come in, I got to start over. But if it's just an exam, that's on you. If you miss the test, it's a 0, okay? Your test, alpha group, your test will be open from 1 to 3. You'll have 33 minutes to take the test once you start it. Okay? If you come in at 1, take it in 15 minutes, you're done for the day. Okay? If you come in at 2:50, you're only going to have 10 minutes to take the test. You don't get the whole 30 minutes because the test is going to end at 3 o'clock. Okay? That's going to give me a time to take a break, get prepared for the next group of students that come at 4. Okay?
So
So,
will the test be on online?
yeah, bring your computer or bring your computer so you can take your test. The test is on Canvas. You'll bring it here and take it on computer. All right. So I will see you guys tomorrow. This recording, like I said, it's recording now. I'm gonna stop it and let it convert and then load it. The homework is already in there. It's not due till 1 o'clock tomorrow. So you got the rest of the day today to study, look back over the lecture, work on your homework. If you have any questions before the exam, I'll answer some of those homework questions. So like when you come in and you say, Ms. McCarthy, I got a couple questions about this. I couldn't figure this out or whatever. We'll go over that before the test. Okay, I don't have a problem with that. I also let students take a blank sheet of paper out. After you have cleared your desk, you can take out a blank piece of paper and write whatever you want to write on it. Formulas, whatever. Okay, because it's coming straight from your mind. I don't care as long as you're not writing it from something else. Once you put everything up but your computer, I will let you bring out a piece of paper. I will give you a scrap piece of paper and you can write down formulas or whatever that you want to help you remember something. And while you take the test, you can use that. Okay, because that's coming straight from your brain. It's not cheating. So you'll take the test tomorrow. You'll be done. Thursday is open for Omega students to be in person. If you want to be in person on Thursday and you are part of the Omega group, you are here. You're free to come between 1 and 6. Now you don't have to stay the whole 1 and 6. If you come in from 1 to 2 or come in at 2 to 3 or whatever you want to do, that's your business. Okay. I'm not really worried about that. If you decide to come, you come. If not, stay home. Okay. But I'm going to put the recording up as soon as we get off of here. The homework is already up. It's due by 1 o'clock. I will see you guys tomorrow. Good luck. Make sure you read, take your notes. I will answer any questions you have before the exam tomorrow. Have a good day.